two things at once. Making Maria a co-host and talking at the same time is a bit much for a specialist. So Maria, do you want to talk a little bit about the fundraiser? And while she's doing that, if you were hoping to present a case or volunteer, maybe you can tell us in the chat so we know. And we have very exciting thing that Maria and Sukriti have put together to try to raise some money for what's going on in Ukraine. Do you want to talk a little bit about that, Maria?
Yay,
I'll keep an eye on the chat for.
Thanks for the shout out. First, congratulations to everyone who matched. I know this is a very exciting week for a lot of you. And then we do have news for Friday. I know it's also match day, but we are coming together, all of the CP Solvers team, and doing a fundraiser to raise awareness about Ukraine and hopefully raise some money to an organization. We're going to put all the details soon. And we have not one event, but 4 events that on Friday. So we're going to have RLR, Neuro VMR with Aaron. We're going to have Charmaine and Jack in the evening. And then a little bit later, Steph and Salvin. So we're going to have 4 VMRs so that everybody can log in whenever they can, come in, hang out, have fun, discuss a case as always. And then hopefully we can motivate some of you to increase awareness and raise some money that day. So we'll be here almost every hour of the day, 4 hours of the day together in special VMRs.
Thanks, Maria, and thanks to you and Sukriti for figuring out a way that, I think all of us start to feel or can start to feel useless in times like this, chipping away at our own tiny corners of the world, trying to do the work that we do. It can feel hard to relate it to these bigger things, but Maria and Sukriti have thought hard and creatively how we can use what we do here to try to raise some awareness and hopefully some funds for people who are working on the front lines. And so the idea is like a concert festival. Like people say, we're going to have a big concert and have all these music events to raise money and draw people. Well, I don't know if anyone here sings. You wouldn't probably want to hear me sing the 90s rock songs I listened to in the car from growing up. But if that'll earn some more donations, I'm happy to do it. So we're doing what we do, which is sort of a concert festival of VMRs. We acknowledge it's match day, and some people will be celebrating. Some people may be between their lunch celebration and dinner celebration and want to join one of these. So the neurology one will be at noon, and I'll be excited for that. So would anyone like to discuss a case this morning, or did anyone bring a case they would like to present? Anyone bring a case they were hoping to present today, a neurology case? Okay, we always have some backup cases there. Let's try this. Anyone was hoping to discuss today or would like to discuss? Ideally, one person identifying as a woman, one identifying as a man. Would be great to discuss the case. If you're thinking, I don't know, it's neurology, I thought it was something else. I thought it was going to be renal failure, electrolytes, not neurology. Well, that's okay. It's neurology. We'll have fun. We'll learn together. Anyone? Maybe you're thinking neurology is not my first language. I forgot my second line of my my stand-up routine. Maybe you're thinking English is not my first language. I might not know how to say certain things in neurology in my language. No worries. We have Spanish speakers and Portuguese speakers and French speakers here to help you. Diane, that would be great. Angelita, that would be great. There you go. Perfect. And I think, Doug, do you have a case, or Gabby, or? So
I'm happy to present a case if no one else has.
Fantastic. So Doug, Diane, and Angelita, would you like to introduce yourselves? Tell us where you're from, and we'll go ahead and get started.
I am so stressed. I don't even know why. So I'm Diane. I'm from Haiti. I'm a physician. I did internal medicine. I actually did 1 year in neurology in a fellowship that Dr. Berkowitz implanted in Mirebalais. So I'm stressing out because I hope that I will do good. so that everyone doesn't think that it was a waste of time the year that
Oh, please. Dion and I know each other since she was an intern, and she is so brilliant, and we were so lucky to recruit her to do some training with us in neurology. So no worries, we'll be excited to discuss this case with you and our first participant from Haiti, which is wonderful for us. Great, Angelita.
Hello, my name is Angelita. You can call me Angel. I'm a general practitioner from Indonesia, in small town called Bogor. Well, yeah, today it's my first time to discuss neurology morning report with you. Well, I hope I can learn a lot from you, Dr. Berkowitz. Thank you.
Thank you. Please call me Aaron. We're all friends here, so no worries calling me doctor. Well, thank you so much for joining us. Just out of curiosity, what time is it where you are? Angel.
It's 11 p.m.
Wow. Okay. It's 9 a.m. here in California. So wonderful to be spanning the world today. And Doug, from a few hours up north from me, do you want to just say hi, introduce yourself, and we'll go ahead and get started.
Sure. I'm Doug Pett. I'm a fourth-year neurology resident at UCSF. Going to be a neurohospitalist fellow next year, or in a couple of months, I guess. Really happy to be here and honored to be able to present.
Great. So Angel, you said it was your first time discussing. I'm not sure if it's your first time with us, but Doug will present little bits of the case, and then you and myself and Dion will talk a little bit about that part and what we're thinking, and then we'll learn some stuff together, and then Doug will give us a little more information, and we'll analyze that and try to, by 10 a.m., have a pretty good idea of what we think is going on, and then Doug will reveal the final diagnosis, if there is one. Okay, so Doug, would you like to tell us the chief concern, chief complaint this morning?
Yeah, sure. The chief concern is slurred speech.
Slurred speech. So, Dion, what comes to mind when you hear slurred speech? What are you starting to think about?
Slurred speech. Well, I'm thinking, when did it start? What exactly are they talking about when they say slurred speech? Like, is it someone that we cannot understand what they're saying, or is it, trying to understand exactly what slurred speech means? I'm thinking, is there anything else associated with it? Is there any like weakness or like facial weakness or any like focal deficit associated with it? Yeah, that's what comes to my mind. I'm thinking about a lot of things.
Yeah, great.
Is there any disease that the person knows that they have, like hypertension or, yeah, basically.
Yeah, perfect. So let's pick up on some of the great ideas that you had. So you said you're wondering what's really meant by slurred speech. What neurologic entities are you thinking of when you hear about slurred speech? What that a patient or their person bringing them to the hospital might say slurred speech? What sort of medical neurologic things are you thinking of, Dion, that could cause that description?
You're talking about like what disease or what? Okay, so I'm thinking.
What mechanism, what neurological things, right? Yeah, not even the disease yet, I was thinking.
Okay.
Yeah.
So I'm thinking it could be dysarthria, like related to maybe a stroke or anything that has to do with I'm blanking right now.
No, you're perfect. That's exactly what I was asking. Yeah.
So yeah, it could be dysarthria. It could be someone who's actually having like a really severe altered mental status and not being able to speak properly because they're too like maybe weak or like too altered mentally.
Yes.
What else? Slurred speech. I can't think of anything else right now, but if it comes to mind, I'll definitely.
Perfect. Yeah, that's exactly what I was getting at, and that's a perfect discussion, right? So Doug is a neurologist, so probably straight shooting here and using slurred speech to tell us he's thinking of dysarthria, but we'll see. And Doug has a good poker face, so we're not going to know if we're on the right track or not. And so is this dysarthria, or Dion had the very interesting thought, right? The patient's speech could be described as slurred, but is it really some type of language problem? Is it aphasia? The speech itself shouldn't be slurred, but maybe that's how it's being described by the person or by the person who's bringing the patient. Or is the patient just confused? And as a result of their confusion, their speech doesn't make sense and the description is slurred speech. Those are great first thoughts. And as you said, then the question will be, when did this start? Did it start suddenly or gradually? What other focal deficits, if any, are there? All of the same questions I was thinking and same thoughts, Dion. So let's take for now that Doug is probably referring to dysarthria, which means failure to articulate or difficulty articulating. So to localize that problem, we need to know what goes into articulation, right? So at the most basic level, there could just be weakness, right? If you've gone to the dentist and gotten numbed up, right, after your speech is slurred, right, you can actually move everything, but you probably don't have the right sensation there to know where things are. So on a basic level, starting from most distally, if there's tongue weakness from a problem with cranial nerve 12, and the tongue is, heavy or not moving properly, that can cause dysarthria. That's called lingual dysarthria. If there's facial weakness, if you have a facial droop on one side, if I give myself, can't move my face on one side, my speech will be slurred from facial weakness. That's called labial dysarthria because it's a problem with the lips. And if there's a problem with cranial nerves 9 and 10, controlling the larynx and pharynx, I can have guttural dysarthria, which is another type of slurred speech. And you can distinguish those on exam. Let me lay out the framework further. So there's the actual articulatory apparatus, which can have various types of being weak, of cranial nerve 7 or upper motor neuron, facial cranial nerve 12 or upper motor neuron tongue, or cranial nerves 9 and 10 or upper motor neuron control. But then there's what controls all of that, right? So there could be a problem with the coordination of the articulatory apparatus if there was a cerebellar problem. Everyone here has probably seen someone who's had too much alcohol to drink and their speech is slurred, right? That's because there is alcohol's effect on the cerebellum causing slurred speech. And then going even more superiorly, right, there's the upper motor neurons, the corticobulbar tract. The bulb, Dion and I know from French, right? La bulbe is the French word for the brain stem. And corticobulbar are the upper motor neurons from the cortex going to the cranial nerve nuclei that control motor, like 5 masticatory and then 7, 9, 10, 12. So we can distinguish these on exam and probably during the history, right? We're already getting a sense. So if there's labial dysarthria, the patient will have trouble with the sounds p and b. And I'll never forget a patient I saw with Guillain-Barré syndrome who had bilateral facial weakness, so she couldn't make a P sound or a B sound. And every time she needed to use the P sound, she learned to hold her lips together in the hospital. So she would say, I just wanted to take a pause here and tell you that I'm having a problem where, and it was because she couldn't make P or B, and I'll never forget that. And then a lingual dysarthria, we need the tongue to say la, 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 right? If you bite your tongue, you can't say la, you can't say ta, ta, ta. Those are lingual sounds. And then guttural is the g and the k sound. So if that's unable to be produced. So you'll hear a neurologist saying, can you say la, 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 la? Can you say pa, 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 pa? Can you say ga, 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 ga? That can help us decide, is there a problem with 7, 9, 10? And if they can make all those component sounds, but they can't make a good syllable sequence like pataka, 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 or one of my mentors used to ask people to say Methodist Episcopal, these complicated syllable sequences, those could indicate a problem, a cerebellar problem or a higher order sort of motor problem causing a spastic dysarthria. So presuming this is slurred speech and not confusion or aphasia, we'll be able to characterize when we get to the exam where along the system this is. And in the meantime, as Dion said, we'll be very interested to hear on this history, when this started, how long it's been going on, does this patient have a past medical history, how old are they, and all of those things. So maybe we'll have Doug tell us about the history, and then Angel, we'll see what you think based on the history is going on here.
Sure. So this is it's a 27-year-old man with a history of gastric adenocarcinoma that's been metastatic to the lymph nodes and the peritoneum. He's on chemotherapy. He's currently admitted to the hospital for complications of his treatment and his cancer, generalized pain and feeding difficulty. So We were consulted in the hospital, because this dysarthria is just something that came up on the review. It's something that family had talked about, kind of like on day 2 of the hospitalization. It's not why he came in. The story is that over the past 7 or 8 days, he reported progressively slurred speech, difficulty kind of saying all types of words. It was persistent. It didn't fluctuate. He thought maybe it had been getting a little bit worse over the last week. When it had been going on. He also had gait imbalance, which was new, and multiple near falls, and then a fall the morning before he presented. Also something they didn't really report. He came in because he was having trouble tolerating his feeds. Over roughly the same period, he had mild blurring with near vision. He said he had a lot of trouble looking at his phone. Had to really squint his eyes and kind of move his phone all around in order to try and see what was happening. That had never been a problem before. He had otherwise in the background ongoing weight loss and odynophagia due to his NJ tube and abdominal pain, which had frequently for months been interrupting his feedings. So feeding has been a big issue. Other than that, he denied any kind of frank diplopia, vertigo. He had no headache, no neck pain, generalized fatigue and weakness, but no sort of focal weakness, and didn't have any sensory changes. Can share a little bit more past medical history. So he has the cancer that I mentioned, gastric adenocarcinoma, had been diagnosed about a year and a half earlier. He had a recent cancer-associated pulmonary embolism and was on heparin, had been for a little while now, and then had a recent admission for Achilles ascites requiring an NJ tube placement, and that unfortunately was complicated by a very bad hospital-acquired pneumonia, and he was now on oxygen at home and at the hospital. His medications, he is currently on a chemo regimen called Folfox, so folinic acid, 5-fluorouracil, and oxaliplatin. He'd previously been on a modified version of that Folfiri, which has the addition of irinotecan. And then he was also recently started on methadone and Norco for pain. He's on multiple antiemetics. Social history, no tobacco, drug, or alcohol use. He is just an absolutely lovely person, very positive attitude, very engaged with the community and with his family. Loved to work as a camp counselor in the summers and had some other jobs after he had graduated about 4 years ago from college. Maybe I'll stop there.
Sounds good. Wow, there is a lot of information there, and we'll talk about one of the themes today, maybe how to process a case with a lot of information. But Angel, there is a lot here, and so up to you if you want to make some general points of what's coming to mind, or in some instances might be helpful to just pick out part of this and say what's coming to mind related to that, and we'll see what we can piece together. Either of those approaches or any other approaches is completely fine too.
Okay, thanks, Aaron. In my opinion, based on your localization and time course, the localization is hard to distinguish between is it intracranial or extracranial. I suspect there is a highly metastatic carcinoma from gastric adenocarcinoma because he had a past medical history of that. And then I want to ask, is he look frustrated or not? Because I suspect also if he has a Broca's aphasia or not. And then I probably suspect any metabolic condition causing the dysarthria.
Those are all great thoughts. Angel, you made a very subtle and wonderful clinical point. Why did you ask if he's frustrated? Can you explain that for people who might not know what you were getting at there?
Because he had a slurred speech that has worsened. And then I want to know if that slurred speech make him stressed or frustrated, because maybe he know what he's thinking about, but he cannot say it properly.
Yeah, very good.
And it's usually caused by Broca aphasia.
Yeah, so that's a great point. Between Broca's and Wernicke's aphasia, Broca's is the productive aphasia. The patient knows exactly what they want to say, but has trouble saying it in general will appear frustrated, whereas with Wernicke's aphasia, which we learn them sort of similarly in medical school, but my experience Wernicke's, just because of the vascular territory it's in, is much, much less common. But the patient is not aware that they're not making sense and classically will not appear bothered by it. Little tricky here, because if the dysarthria is severe, he could be frustrated by that too, right? By his speech not sounding as he, people not understanding what he's trying to say. So I agree with you. Once we hear cancer in this patient, it's hard not to anchor there and wonder whether these symptoms are in some way related to the cancer. And you mentioned the possibility of metastases. Did you have a particular thought, Angel, on where these metastases would have to be to cause this syndrome of dysarthria and gait imbalance and maybe some other things here?
Could you please tell me? I'm stressed out. I don't know.
No problem. Yeah, it's a hard question. And actually there's multiple answers that are possible at this stage. Dion, did you have thoughts on the possible, let's say we're not sure yet, and I'll give some other thoughts in a moment, but just to pick up on Angel's idea, what if there's metastases of this gastric cancer to somewhere in the nervous system? Where might they be to cause some of these symptoms? Oh, I think you're muted, Dion.
Sorry.
No problem.
Yes, I am thinking it could be cerebellar with the gait imbalance and the slurred speech. I wonder if, like, how's it called? Le tronc cérébral.
Yeah, brainstem. Mm-hmm.
Brainstem, but in it would have to be like posterior, so maybe something that has to do with the posterior cords and also at the level of the cranial nerve 12, or like, if it's possible, I don't know, but that's what came to my mind thinking about it.
Yeah, those are great thoughts, right? So could there be cerebellar metastases here causing both dysarthria and gait dysfunction? Brainstem metastases, presumably there'd be a lot more going on. Maybe we'll find on exam that there are cranial nerve palsies and long tract, so-called long tract signs, corticospinal or ascending sensory pathway signs. But the condition of leptomeningeal carcinomatosis, sometimes called carcinomatous meningitis, they're actually metastases to the meninges, and often multiple cranial nerve palsies are part of that. And on the scan, you can often see contrast enhancement layering in the fovea of the cerebellum. So let's zoom out a little bit. When this is a case that I can imagine Doug seeing on a consult service in a tertiary referral center, and we think of a lot of the neurology cases we've seen here are ones that are sort of quote unquote pure neurology. Patient has a stroke, patient has a seizure, patient has Parkinson's disease. But a lot of what neurologists do when students ask me, oh, but neurology, I don't want to forget about all the other organs, as Doug and Gabby can attest, is we do neurology consults all over the hospital. And Dion can attest too, from working together in Mirebalais. We're asked to see patients on medicine, on surgery, on OB, on pediatrics, on the cancer wards, and have to really think about a lot of different Venn diagrams, right? Of what's the neurology of? What's the neurology of the postpartum period? What's the neurology of cancer? And this is what I call with my students and residents neurology in the wild, right? Because you have to see this patient where there's so much going on and say, is there a stroke buried in here somewhere? Is there a seizure buried in here somewhere amidst all of this, long chart and complicated history? So it's helpful to have a few useful kind of frameworks for common things. And one is, what is the neurology of cancer? So, and again, not talking about brain tumors specifically here, but a patient with a systemic cancer has a neurologic symptom. What are the possible causes? So Angel mentioned one, and that's metastases. So that's what I would call direct involvement. There is tumor either in a nervous system structure, brain, brainstem, spinal cord, rarely even nerves, plexus, or there's cancer compressing another structure, right? So that's direct involvement. Or there's a whole neurology of chemotherapy and radiation therapy and immunotherapy. And neurologists know the most common neurologic effects of the common chemotherapies. So Doug mentioned oxaliplatin. Okay, if nobody knows this is rarefied neurology. Does anyone know what the neurology is of the platin medications?
If I remember correctly, it gives polyneuropathies to people.
Good for you. Yeah. So remember the platins, the taxanes, they're preventing the cancer cells, fast dividing cells from dividing. And how are they doing that? By inhibiting microtubules. Remember the microtubules line up and pull the nucleus apart? Well, those really long axons are using microtubules to get stuff down to the synapse, neurotransmitters and whatnot. And so microtubule inhibitors very commonly cause a peripheral neuropathy during treatment that in many cases goes away, though can persist. Oxaliplatin has a unique feature where there are cold-induced paresthesias, or when the patient feels cold air on their extremities, it causes painful paresthesias. That's specific to oxaliplatin, not the other platins. But causing dysarthria, diplopia, gait imbalance, we shouldn't see that with this drug, but that's why it's always helpful to know there is cytarabine can cause an acute cerebellar syndrome. So what is the neurology of different chemotherapy? So we talked about direct effects, neurologic complications of treatment, and then paraneoplastic syndromes, where some disimmune process probably involved in the immune system trying to fight the cancer ends up with some friendly fire against the body. So let's see if any of those could fit here. I agree with both Angel and Deanne when we hear about dysarthria and gait dysfunction. That package definitely makes us think about the cerebellum, though I guess you could have an internal capsule lesion causing weakness both in the face, tongue, and also in the limbs that could cause some gait. But what about that difficulty with near vision? Does anyone know what do our eyes do when we're looking close up? What do they have to do? Do you know, Angel or Deanne, when we're looking at something close to us, which we spend most of our lives doing now, what do the eyes do?
Like accommodating.
They accommodate so that pupils get smaller, and they do one other thing. You did it with your hands, Deanne. What do the eyeballs do? I think I saw you doing it with your hands.
Inward, outward, maybe.
Yeah, they converge, right? So when you look at something close to, the eyes converge. When you look at something far away, the eyes diverge a little bit.
Yeah.
And so how do we converge? Which muscles? Those are the medial recti, and they have their own sort of pathway, the convergence pathway that goes around some of the other conjugate gaze pathways. And so medial rectus, do either of you know, Deanne or Angel, which cranial nerve innervates the medial rectus?
It's nerve 3.
Cranial
Ocular
nerve 3,
motor.
perfect. Yep. And what level of the brain stem? Midbrain, pons, or medulla?
It's on the midbrain.
Midbrain, perfect. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12. If you're in a pinch, there are some exceptions, but 3 and 4 and all to do with vertical gaze are up in the midbrain. So could this patient, as Deanne mentioned earlier, have some type of dorsal midbrain lesion affecting the convergence pathway in the cerebellum? Probably if that's the case, we'll see a lot more problems with their eyes on the exam. Or does this patient have a process affecting those that's not a lesion? So again, we all know this patient's going to get a scan, is going to need a scan of the brain, right, to figure out is there cancer there, metastases. We said the chemotherapy shouldn't really do this. Presumably the patient has had no radiation to the brain that should, which can do lots of things, but the patient hasn't had that. And then could there be a paraneoplastic syndrome that would go along with this sort of posterior fossa syndrome? Any thoughts on that, Angel or Deanne? Again, this is getting into what we might call gourmet neurology, but Doug is a gourmet neurologist and may have brought us some gourmet neurology today. Anyone know of a particular paraneoplastic syndrome, or what you would call that syndrome, just sort of syndromically? Yeah, so could this patient have paraneoplastic cerebellar degeneration? Wouldn't really explain this convergence thing to me, but that's a common syndrome, particularly common with ovarian and breast. Can be caused by anti-Hu and can be caused by, anti-Yo. Someone just put in the chat, good for you. Anti-Yo, anti-Hu can do anything, so it's on all the lists. So with the paraneoplastic syndromes, the list of antibodies, I was just revising for the second edition of my book. My table for antibody-mediated neurology syndromes in my first edition is 1 page, and now it's 2 pages in 5 years. That's how many there are. So it's helpful to just think syndromically, is this a cerebellar syndrome? And there's certain antibodies that only do one syndrome, like the NMDA receptor antibody that causes NMDA encephalitis. It doesn't do anything else. But then there's other ones like anti-Hu that can cause a neuropathy and a ganglionopathy, encephalopathy, myelopathy. They can cause kind of anything. The other syndrome we could invoke here, aside from a cerebellar one, would be something called a rhombencephalitis, which would be a sort of brainstem encephalitis. And there are antibodies that can cause that. Recently described one called Kelch-like protein 11, I think I was reading about. I think it's more common with testicular cancer that causes a rhombencephalitis, meaning a brainstem encephalitis. And these are immune-mediated syndromes, so that's possible here. And then sort of in the category of paraneoplastic is patients with cancer, particularly mucin-secreting adenocarcinomas, are at increased risk for stroke. That's the Trousseau syndrome, hypercoagulability of cancer. So if someone told me I have a neurology patient for you with a history of gastric or colon or pancreatic cancer, my first thought that's coming to mind is, did this patient have a stroke from this hypercoagulability? And as my mentor and wonderful teacher of neurology, Marty Samuels, taught us when this came up, Trousseau syndrome is one of the few that deserves the apostrophe, because Trousseau not only described this syndrome, but died of this syndrome. He developed a clot in his leg. There's a Latin name for it, phlegma albans dolens, something like this. And he said, I bet I have a gastric cancer. And there's a very moving paper called something like Trousseau's Last Christmas, that he was estranged from his son, and he was telling his son he believed he was dying of the disease he described. So could this patient from gastric adenocarcinoma have a hypercoagulable state, and in the setting of being very debilitated and sick from this cancer, had either a stroke or a couple of small strokes that have caused these deficits? So we have the possibility of metastases, probably to the posterior fossa, to a paraneoplastic syndrome involving the cerebellum and/or brainstem, and the possibility of a stroke or multiple strokes from a hypercoagulable state. And we also considered whether chemotherapy could have caused this, and said probably not, though we may find an incidental neuropathy on the exam that we might blame on oxaliplatin. Okay, so great discussion so far, Dion and Angel. So Angel, you discussed the history, so I'll ask you to discuss the exam, Dion. So before we hear it, what in particular, obviously we'll do the whole neuro exam, and Doug will tell us in detail, what things are you looking for in particular to help us with our localization here?
Well, definitely his reflexes for sure, to see if it's hyperreflexia or hypo, see if he has any, so for the mental status, see if he has any other, like, besides the language problem, is there anything else associated? So for the motor exam, try to figure out if he has any focal symptoms that are associated with it. For the cranial nerves, is there any other nerve that is, so if we're thinking 12, like, is there any other nerves close to it, like 11 or 10, that are also involved? What else? Yeah, basically the coordination and Romberg. Yeah.
Perfect, excellent. So I agree, yeah, probably the most interesting things for us here are going to be the cranial nerve and cerebellar exam, to see if our suspicion of cerebellar pathology is manifested with things like nystagmus, with the so-called scanning dysarthria. I never really understand why it's called scanning dysarthria with cerebellar, but cerebellar dysarthria sounds like what the finger knows looks like the volume is really going up and down. It sounds like someone, for people who used to have radios, like I did growing up, if you were a kid and just play with the dial and move it like that, that can sort of, the cerebellar speech can, I don't know how that got the name scanning, maybe Doug or Gabby know where that comes from.
I think I thought you were going to say, what I have heard is that it's when, on old radios, when you're scanning through different frequencies and you're getting the different radio stations, it's like,
yeah.
It sounds like that, and it sounds like scanning.
Oh, I don't know. People now say scanning like a scanner. I say, no, 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 this was before scanners, but I didn't know the radio was just my idea. So, and we'll be curious what the pattern of dysarthria is and what the eye movements look like. So I agree with you, Dion. Those are the things I would zero in on. And as you said, are there other things the patient didn't mention that will, there's some hyperreflexia or there's weakness in a particular pattern that would help us know that we're not just in the cerebellum. Okay, Doug, what did you find on this exam?
I'll just say real quick out front that I'm just like super, it's really amazing the reasoning that went in up front leading up to the exam, kind of by everybody involved, because now you're not starting with just a blank, neuro exam template. You've kind of like formed a little circle around each tiny piece of it where you're saying, if this is not there, that's going to raise our eyebrows. If it is there, we're going to we've already done the work with this. And that's just that's what makes this reasoning, the pre-exam reasoning, so interesting. And I'm just really impressed and inspired. So,
well, since you said that, but before you go, I agree 100%. And just anyone who's hasn't just matched or already decided on neurology, or you're still checking things out, we'll just put in a pitch here for what we love, that when we get to the exam, and I've been doing neurology, including residency now for, let's see, since 2011 or something like that. So over 10 years. Is that right? Yeah. Including residency. I still, whenever I get to the exam, I get this excitement that I think I have a pretty good idea, but I'm going to know at the end of this exam certain things. And I know that I might get a surprise that's going to make me stop and rethink. Even when I look at the patient, I'm pretty sure this is Parkinson's disease. I'm so excited to see, well, is there really rigidity or am I mistaking something? Is that tremor going to go away when the patient does finger nose, or is it going to get worse? So this is what Doug and Gabby and Dion and others that have fallen in love with this field of neurology, one of the many things that is just so interesting and fun for us. Okay, Doug, so sorry to delay that excitement here, but tell us what you found.
Yeah, so the patient's afebrile, he's tachycardic to 110, and that's been pretty consistent over a few days. He's on 2 liters nasal cannula, also consistent. He's cachectic with a supple neck. And then neurologically, he's a little fatigued but alert. He's fully oriented. There's no aphasia with detailed testing. The speech really does have a scanning quality to it, where the volume is kind of going up and down and the speed is kind of increasing and then slowing down. It's very inconsistent. Cranial nerve specifically, he had normal fundi. He had normal acuity. His extraocular movements were grossly intact, but he had a right exotropia on cover-uncover test. He had a very prominent global dysarthria with PA-TACA testing and could not do PA-TACA in a constant tempo. There was dysmetria and loss of check in both arms, and his gait was wide-based and unsteady. The motor exam and the reflex exam were normal, and then there was mild decreased sensory sensation to vibration in the toes, but otherwise intact. And
great, yeah. Very interesting. Okay, Dion, what do you think as you see some? You can again take the whole thing en gros, or you can pick off a piece here and tell us what you're thinking.
Okay.
Sorry, I have trouble not speaking in French with Dion since we spoke French and Creole every time I've seen her. So I think I just accidentally spoken some French, but I guess we use that sort of expression in English anyway. I'll try to keep. I can't resist. Go ahead.
Okay, I also have a question regarding the exam, but I'll ask it after, because there's one thing that I really understand. Yeah. So I don't know what mild exotropia is. I'm not sure I understand it. So
great. I'm going to ask Doug actually to explain, if he doesn't mind, what mild exotropia is and how it manifested on the exam. Or actually, let's do this. Let's take that out for a second, Dion, because it's tricky and I'm still in my head working through it. How about do you want to tell us some of the other stuff, and then Doug will add that piece in for us?
Yes, definitely. So what I'm thinking about, I didn't expect the reflexes to be normal, to be honest, but if they're normal, okay, it means it could be upper or lower motor neuron. We don't know for sure. The fact that on the cerebellar exam, he mentioned dysmetria and a wide balance gait, which makes me think it might be something that has to do with the cerebellar, or since the patient also had the vibration in the toes that were also impaired, it could be like the posterior cords and proprioception. And someone mentioned in the chat B12 deficiency, and it makes sense, even though there are things that do not really fit in the description of B12, but it could also be because of his gastric problems, so difficulty like my English, difficulty with the factor, I think it's like intrinsic factor that could make him not be able to process the B12. I know
Yeah.
process is not the right word, but you get what I'm
No,
saying.
you're perfect. And if you need to drop into French or Creole, Dion, go ahead, and we have that all the time here. People dropping into other languages, and we'll put it together. Don't worry.
So what else? So I'm not too sure that it has to do. I don't know what the exotropia means, so I don't want to talk about the cranial nerves, but I expected to see more in the cranial nerve exams, to be honest, but
Yeah, I agree. That is interesting. So Dion made a very sophisticated, important point here, and that's that not all ataxia is cerebellar, right? Because the cerebellar is only as good as its ins and outs, right? And one of the important ins for the cerebellar to coordinate movement is to know where the body is in space, which is proprioception. So a patient can appear very ataxic from a peripheral neuropathy or from dorsal column dysfunction. Even though the cerebellum is healthy, it's not getting the proprioceptive information it needs. So the package of vibration loss and ataxia could localize actually outside the cerebellum. And Dion mentioned the important possibility of B12 deficiency, right? Causing subacute combined degeneration, although we said that probably shouldn't cause eye movement trouble. And if this is true cerebellar ataxia, it shouldn't cause that either. But when Dion and I saw patients together in Haiti, so common, right, to see B12 deficiency from malnutrition and patients wheelchair bound, who fortunately most of the time could get much better when their B12 came back. And we both learned, all of us working together, that they are not always having a macrocytic anemia to go along with it. So they might also be iron deficient, and it averages out and they have a normocytic anemia. And so you can miss that. So B12 deficiency and the cancer maybe is not causing any of the complicated things we talked about. Although, as you mentioned, the eye, whatever the eye thing is, we don't know exactly. It wouldn't fit with that. Or does this patient have a cerebellar lesion as we thought, and the mild vibratory loss is from oxaliplatin and is sort of a separate problem that can be set aside? Or does the patient have multiple problems here, cancer and B12 deficiency and chemotherapy-induced neuropathy and metastases? Also possible in this patient who has some complex medical things going on. So let's add in, Doug, can you tell us what a mild right-sided exotropia is and how you found it and how you localize it? And I'm now going to stop talking and also think about it, because this is, tropias and phorias are very confusing. I have to draw them out to really think about them.
Sure, and just some intellectual honesty on my part, these subtle maneuvers in neuroophthalmology are kind of a white whale for me, something I'm constantly trying to understand better. And I thought about this a lot at the time and wanted to throw it out to the group with what I had landed on. But here's how I think about these. So conceptually, I think of it as the eyes, in order to create one clear image or a single image, need to be lined up. They need to be lined up to avoid diplopia, and the absence of lining up is what produces binocular diplopia. The way I think of it conceptually is that, if there is going to be diplopia, meaning a problem with one of the muscles or the cranial nerves or something that we talk about all the time, then usually you'll see some difference on eye movement testing, kind of in your H formation. However, if you have a very subtle disconjugate gaze, meaning the eyes are a little bit off, then the brain the higher order centers in the brain, the cortex, can do a little bit of editing work to bring them back into conjugate gaze. Meaning that if there's only a small difference in the strength of one of the muscles, then you're not going to see it when you do this, and the patient won't necessarily see diplopia all the time because the brain is causing fixation. Does that make sense? So I think of the brain, when you have a subtle deficit, the brain is sort of an editor, because the brain wants you to see one picture. So in order to detect that slight disconjugate gaze, we need to kind of get rid of that editor. So the way that I think of doing that is something called the cover on cover test, and that there are other tests like this, but this is, I think, one of the most useful ones to know about. Is if you take out fixation, for example, in this case, what you do, we saw this on the right. So what happened is that when I would cover the left eye like this, when I do that, the brain no longer needs to edit any changes in the eyes because I only have one eye. I can see one image with the eyes doing whatever they want. So what happened is I would cover the left eye and the right eye would move out slowly, or not slowly. Whenever I took out the left eye, the right eye would move out a little bit like this. And then I would cover it and it would move in, and it would be like this. Then I would cover it and it would move out. Then and then it would move in. So what that tells me is that when this eye, the right eye, is doing whatever it wants to do, when it's not being edited at all, it wants to move out just a little bit. And what that represents is a little bit of weakness of adduction. Mm-hmm. So when the right eye wants to do what it wants, it wants to move out a little bit on its own. So it's a little bit weak in adduction. And where that maps onto, if you just, so that's equivalent to if I just saw a little bit of my right eye being just outward on movements, I would say, oh, look, there's a, you would localize that wherever you would localize it to. And in this case, that came up. So what that represented to me was a slight adduction deficit, so a slight maybe cranial nerve 3 palsy. Does that make sense? Or Aaron, can you add to that? Or
yeah, it's a great explanation. I always like to say, talking about the eyes can make all of us cross-eyed. It's very complicated, and there's almost everything has some type of opposites, like the visual field, the left visual field is on the right, right is on the left, superior is inferior. And there's a lot of, if you've ever tried to think through the Maddox rod, which I don't use that often, but when I try to think through it, I always have to say, I use my hands like this for the 4 positions. But the way I think about it, Doug, similar to your editor aspect, is the brain wants the eyes to be aligned. And you know this, right? If you rub your eye a little bit, everything goes out of focus, double. And so if the brain if there's a subtle weakness, if there's a major weakness, right, the patient can't adduct, then it's just obvious. You don't need to do this cover uncover testing. The way I think of it is, if there's adduction weakness, the brain is trying so hard to keep the eye adducted. It's putting a lot of extra energy into that. And so when you cover the other eye and it doesn't have to do that anymore, it says, and it relaxes and goes out a little bit. So it's like it's doing extra work in the direction of the weak muscle, so that when you break fixation by covering the eye, it says, oh, I can relax. Or if you cover it and then uncover it, when you cover it, it relaxes because it says, oh, I don't have to do all that extra work anymore. So it relaxes in the direction opposite the weakness. That's where it gets confusing. So the XO means there's a trouble with, means there's a trouble with adduction. Again, going along with this trouble looking at things close up, that there is some problem either with convergence, cranial nerve 3, the medial rectus, or the neuromuscular junction. So again, we can't blame that on our friend B12, though there may be B12 deficiency here as well. Okay, there's a lot going on here, and we're getting close to time. And if this is like any other case from Doug, we may have 12 more aliquots here, but I don't think so in this case. Angel, if you had to get one test, if you could only get one test to figure out what's going on here, what test would you get next to try to figure out what's going on?
I would love to order an MRI.
I would 100% agree with you. And if we got an MRI of the brain, would you, if you were asked by the radiologist, do you need contrast on this study? Would you order contrast as well?
I would love to add some contrast.
Yeah, I 100% agree with you. Why do you want to get contrast in this study?
I don't know what's the English penyengatan.
Oh,
Uh,
that's anyone else here speak? I'm sorry, what language are you speaking?
Indonesian.
Indonesian. Anyone else help us with that? Can you say around what you're trying to tell us? I'm sorry.
Maybe the contrast want to show up the tumor a little bit more.
Enhancement, maybe you were saying.
Enhancement, yeah. Sorry.
All right, we figured it out. Yeah, so contrast enhancement, right? Because a tumor will enhance. And actually, if we're looking for a leptomeningeal disease, so if you did a non-contrast scan and there's a big tumor in the cerebellum, you'll see it. You just won't be able to characterize it that well, but it'll be obvious there's a mass there. But you could miss small tumors without contrast, and you could miss this leptomeningeal enhancement if there's leptomeningeal carcinomatosis. So I agree that's the next test. What are we going to see there? Is there a metastasis in the cerebellum? Are there leptomeningeal metastases layering in the fovea of the cerebellum and getting just one sort of fascicle of the third nerve on its way to the medial rectus, causing a partial third? I guess that's possible. Or if we saw nothing, then we'd really be thinking, is this some paraneoplastic syndrome? And with a sort of hard brainstem finding there, maybe we'd be calling it a rhombencephalitis. So it doesn't seem that there's not much else going on in the brainstem itself. So I'm not sure. Is Doug going to tell us, hey, I found a case report of B12 deficiency causing cranial neuropathy and all these things, because common things are common and common things can do rare things too. I certainly haven't heard of that, or oxaliplatin causing all this. I wouldn't think so. I think I would be between seeing metastases, as Angel said, either cerebellar and or leptomeningeal, or the possibility of a paraneoplastic syndrome. Or I guess, coming back to, again, common things being common with a mucin secreting adenocarcinoma, will we see a couple of small strokes, maybe of different ages? And some are so small they didn't cause anything, but some are well placed in the cerebellum, well placed for explanation, not well placed for the patient, in the cerebellum and brainstem to cause this. Other things we could see here, Dion, other things that were on your mind aside from tumor, stroke, or nothing, or calling it paraneoplastic? Any other thoughts you had?
No.
No. Okay. So what did you and your colleagues find on this MRI, Doug?
I don't know. You tell me. I'll pull up a picture.
So we'll do some radiology here.
And I'll say I these are just two shots, and in order to de-identify this, I really couldn't have it dynamic. I tried, but
no worries. We understand.
Let me see what I can do here.
I think the last case Doug presented us was Balamuthia mandrillaris granulomatous amoebic encephalitis. So there may still be he may still have a trick up his sleeve here. Okay, so I think you're up, Dion. Do you want to tell us what I know? We only had CT scan usually to work with.
I was hoping it would be Angel.
Well, we can work together. Anything that you see here? Are you familiar with these sequences, Angel or Dion, or should Doug and I explain them?
I would rather let you explain.
No problem. Angel, do you know what this flare and T1 plus contrast suggests, or what they mean, how we use them?
Explain, please, Aaron.
No problem. No problem. So FLAIR stands for fluid attenuated inversion recovery. And what it is so the base MRI sequences are T1 and T2. And in T1, as you can see on the right, the gray matter is dark and the white matter is lighter. On a T2 image, it's like the inverse, if you remember the old kinds of photographs before phones, where you had the negatives, the black and white are reversed, right? And the colors are reversed. So in the left image, the gray matter is bright and the white matter is dark. And in a pure T2, the CSF is also bright. And what the FLAIR does is a T2 image subtracting out the CSF signal, so we can more clearly see around the ventricles if there's any brightness. And usually FLAIR is the sequence I start with because it'll show us in general if there's any obvious pathology, but it doesn't tell us specifically. So anything bright on FLAIR could be tumor, stroke, infection, inflammation, demyelinating lesion, whatever. And then the next place I usually would look is the other image Doug has. So we have a similar approach here, is a T1 image after contrast. And technically you'd want to compare that to the T1 pre-contrast to see if anything is, you can see things that are bright on T1 and then they'll be bright without contrast, but you might be fooled and think they're contrast enhancing. So what do we see here? The abnormality is pretty subtle. And unless you look at a lot of MRIs, you might not notice. But if you look on the left image, you can see that we're at the level of the midbrain and the fourth ventricle. If Doug could put his arrow there, yeah, that's the midbrain. And just behind that is the very superior aspect of the cerebellum. And for me, the fovea, the spaces there are a little bit bright, and what Doug is pointing to. And when we look at the right image, the brain parenchyma actually doesn't have any abnormal enhancement, but you shouldn't see that brightness kind of sitting in the folds of the cerebellum there. And that's those are the fovea. If you remember dissecting the cerebellum and anatomy, it has these beautiful, looks like fern kind of plant kind of shapes there, fractal shapes to get as much tissue packed in to a small space. And you shouldn't see an enhancement in there. And you do, and that's a very common place for leptomeningeal disease. And is there some pachymeningeal enhancement there, Doug, anterior to the temporal lobes as well, or had this patient had a lumbar puncture at this point?
The MRI came before the lumbar puncture, and I think I would say it's totally unfair of me to show one static image and one cut and everything, but it was exactly what, and if you could see through the whole cerebellum and even some supratentorial spaces, there was leptomeningeal enhancement, not so much pachymeningeal throughout the brain, but by far most prominent in the cerebellum and in the midline cerebellum particularly. What Aaron was pointing out over on the flare side, one thing I always remind folks is that when you're looking at flare, you're not looking at an enhanced sequence. There's no contrast. So this is not enhancement. This is flare hyperintensity. And in this case, what they call it is something called flare non-suppression, which implies that, what flare does, it's a T2 sequence that takes all of the white CSF and makes it dark. So it takes out all the water. And flare non-suppression means that there was something besides water there, maybe something like a protein or an infection or a cancer or whatever, some proteinaceous material that could not be subtracted with the algorithm. So it tells you there's something else that's gunking up the CSF right along the meninges and probably usually sticking to the meninges right there. So this is flare non-suppression on the left, and this is contrast enhancement on the right. So it's exactly what Aaron was saying.
No parenchymal metastases, Doug, just lepto.
There were no parenchymal metastases, but there was also potentially some asymmetric enhancement of various cranial nerves, the sixth cranial nerve and the third cranial nerve. And then the only other thing that you catch a little bit on the left is you can see these temporal tips of the lateral ventricles. There was maybe a question of early hydrocephalus, but nothing whopping. This is a 22-year-old or 27-year-old or something.
Yeah, so it's interesting. In my experience, you can tell me if you agree, Doug, and Gabby, if she's still here. Usually patients either get leptomeningeal metastases or brain metastases. It's not that common in my experience to see both together. Dural metastases you can also see with in my experience, most commonly with prostate and breast. And usually those also, it sort of goes to the dura or bone, but not to the brain. It's almost as if the cancers have a certain seed and soil propensity that for whatever reason they like either the parenchyma or the leptomeninges, and that can be very individual. I've seen patients with breast cancer who have tons of parenchymal mets and no leptomeningeal disease, and some who have the opposite. So it's probably specific, not just to the type of cancer, but to the cancer itself, although maybe Doug learned in this case about particular propensities. Unfortunately, this is usually a very, very poor prognostic sign in most cancers if the cancer has found its way to the meninges. But this very unfortunate young man, Doug, tell us what happened next. For me, this would be enough information. If you didn't know the patient had cancer and the primary was not easy to find, you might do a lumbar puncture and actually diagnose the primary cancer by doing cytology of the cell type in this cerebrospinal fluid, but in a patient with a known advanced cancer, and this finding on MRI would probably be enough to talk to the oncologist and see if that changes their treatment and prognosis. But tell us in the last few minutes here, Doug, what happened next for this patient and what the oncologist thought, and any teaching points you had related to this case. I saw you had a whole slide deck there.
So at this point, you know, like Aaron said, we were on the same page. We were very concerned for leptomeningeal metastases as the most likely diagnosis. Because he was immunocompromised and kind of borderline leukopenic, but had been quite leukopenic in the past with his chemotherapy, we were also quite worried about infection and felt like, you know, while leptomeningeal carcinomatosis is very high on our differential, you know, an infection would be treatable. So we thought a lumbar puncture would be meaningful to see if there was something we could treat. We had also considered nutritional complications, you know, earlier after his exam, and we're pleading things like thiamine, but saying that doesn't completely explain the picture. It certainly doesn't explain the MRI. We thought a lot about paraneoplastic cerebellar degeneration or rhomboencephalitis and the types of organisms that can cause those things. And you know, at this point, we're really, you know, looking at a 27-year-old and really hoping we could find something that would be treatable. So it was informative. We got a lumbar puncture. He had a low glucose of 44 with a serum glucose of about 100. Protein was 77. He had 24 white cells that were lymphocytic predominant and were noted to have one other cell, as sometimes comes up on our you know, this is, and then cytology came back in about 2 days with adenocarcinoma. So that was a definitive diagnosis for him. So leptomeningeal carcinomatosis in gastric adenocarcinoma is not common except for extremely late in the disease. Paraneoplastic cerebellar degeneration or paraneoplastic disease at all with gastric adenocarcinomas is extremely rare. You can get it with gastric cancers, but they're usually neuroendocrine tumors, which are more immunogenic. One thing that I found pretty interesting is that, and kind of a trapdoor that you can fall into with when you're working up any sort of CNS or leptomeningeal cancer spread, lymphoma or carcinoma, lymphoma is the classic one, is that both the MRI and the LP, the cytology can be totally normal. So the MRI, the numbers for the MRI sensitivity in carcinomatosis, it's not super helpful. It's something like, you know, it's somewhere between 18 and 87% sensitive or something like that. All that tells me is that a negative MRI doesn't totally rule it out. That certainly wasn't the case in this case, but you would still want to maintain your index of suspicion based on multiple cranial neuropathies in a patient with advanced cancer. And then with regard to the lumbar punctures, the first lumbar puncture, and these numbers are a little bit of a moving target, but the first lumbar puncture in carcinomatosis, when you're dealing with the carcinoma specifically, is really only about 45 to 70% sensitive. It goes up to about 80% on the second one, and it's only above 90% sensitivity on the third high volume LP. And then those numbers are even lower when you're dealing with lymphoma. So if you're trying to diagnose CNS lymphoma, one major study from I think 2012 said that the sensitivity for CNS lymphomatosis on the first LP is between 2 and 32%, which is just incredibly low. So the takeaway for me here that, you know, we had to go in with, but didn't end up, you know, bearing out in this case because everything was positive on the first run, was that you need to think about repeating an MRI down the road and keep it on your differential. And then 2 is that 1 LP often will not get you the diagnosis. So you have to think about multiple high volume LPs.
Yeah, great teaching points, Doug. I think you alluded to something that actually none of us said, and I always forget to think of, which was Wernicke's encephalopathy. This patient has ataxia, eye movement difficulties, and surely has malabsorption. And you might say, but they weren't confused. The triad in Wernicke's is like a terribly sensitive, and most patients have just one or two aspects of that. So it's not just people with a history of alcohol use disorder. It can be from hyperemesis gravidarum. It can be from patients with other nutritional or absorption deficits. So Wernicke's, Doug mentioned giving thiamine, hoping to be treating, find something treatable. That was an important differential that I somehow always forget to remember to think about. Luckily, someone will always think of it. But just wanted to throw that out there, something I often forget. So yeah, great points. This scan had the classic findings of leptomeningeal carcinomatosis. I said, sort of layering in the folia there, but a scan without contrast, a non-high resolution with fine cut scan, even with contrast, you can miss this, and the LP, you can miss this. In my experience, I've never seen someone present with cancer at the stage of leptomeningeal disease. In other words, with an unknown primary. Usually patients are sick enough from the cancer at that point that it's on the differential and you're not sort of really shooting in the dark. The other pearl I learned it was another case of gastric cancer, believe it or not. The patient was having these very difficult to interpret events of posturing with a normal EEG, fluctuating level of consciousness. The EEG was normal. We did a lumbar puncture, just the MRI was normal. We couldn't find anything. And there were gastric cancer cells in the CSF. And I can't remember where I found this, or the resident found it I was working with, looking it up. But there are descriptions of leptomeningeal disease causing this sort of fluctuating elevated intracranial pressure from communicating hydrocephalus. And the ventricles were normal in this patient, but they looked like they were in status. They just kept posturing and then being unarousable, and has been described that these patients can also have these sort of events of fluctuating consciousness or sort of fluctuating seizure-like posturing events from the hydrocephalus aspect. And that patient had normal imaging, and the diagnosis was made on lumbar puncture. This was a very complicated case, as Doug is prone to give us, like I said, neurology in the wild here, where we have to think not just of our neurology schemas, like things for dysarthria, but schemas for neurology of cancer. And I think actually one of the first schemas Reza and I did together was neurology of cancer. It might be somewhere on the CP Solvers website. So with that in mind, really brilliant discussion, Dion and Angel, who both wrote in the chat, I'm stressed out, I'm nervous for neurology morning report, but you both did an amazing job here discussing this case and coming to the diagnosis relatively quickly, right? Which is when there's cancer, we have to think outside the box, but often cancer is the answer in one way or another. Maria keeps enlarging the teaching points box for those of you who are still with us. You want to share some of your teaching points from this case, and then we'll wish everyone a good day, and we understand if people need to run. I warned you, if it's coming from Doug, from a quaternary medical center, one of the only major medical centers with hundreds of miles around it in Northern California, it's going to be something complicated. So thanks to those who took a longer time with us today. Go ahead, Maria, if you have time.
Yeah, this was an amazing case. Thank you, Angelita and Diane, for discussing with us. I learned so much from all of you. We started with slurred speech, and I like how we divided it into dysarthria, aphasia, or altered mental status and confusion. And so dysarthria, really think about it as an articulation problem, and then you can localize it depending on like the features you get. It can be lingual, labial, guttural, cerebellar, or corticobulbar. And aphasia, think more about language. I really like the pearl about Angelina gave us about looking at the patient if he's frustrated. I never thought it about that way, but Broca's aphasia has impaired speech production but preserves speech comprehension, so they are aware of the problem and thus they'll be frustrated, versus Wernicke's, which have preserved speech production but impaired speech comprehension, so they're mostly unaware and unfrustrated. And then we layered it on to near vision, which we learned about the convergence pathways and how that localizes to the medial rectus, cranial nerve 3. Always remember the rule of fours if you want to sort of localize cranial nerves into midbrain, pons, and medulla, and then all of that layered with a previous cancer diagnosis. So we have this very cool cancer neuro Venn diagram. We tend to think about direct involvement, sort of metastatic process. But also we need to remember there's adverse effects of therapy, such as platinum-based chemotherapy, which can give you polyneuropathy, and we learned that oxaliplatin can give you cold-induced polyneuropathy. And we can also think about paraneoplastic syndromes, always tend to think about antibody mediated, sort of like the cerebellar type with anti-yo antibodies, but I tend to forget about hypercoagulability. All cancers are a hypercoagulability state, but also think about Trousseau syndrome, which is a true paraneoplastic syndrome. And then with all of the hints in the history and the physical exam, we localized it a little bit to the cerebellum with the scanning dysarthria, ataxia, wide-based gaze, dysmetria. I think they had a couple, not all of them, but it really came down to the imaging. With the imaging, we saw, well, sort of a reminder that T1 white matter is going to be light, green matter is going to be dark. I always remember that, like, T1 is sort of how it's supposed to be, white being light. And then T2 is inverse, white matter is dark, green matter is light. CSF is bright, and then flare is sort of like a mathematical equation of T2 minus CSF brightness. With flare, non-suppression is something other than the CSF that remains bright, and it can be hemorrhage, meningitis, like an inflammatory process, or malignancy. And the MRIs showed us leptomeningeal enhancement, which Doug taught us that leptomeningeal carcinomatosis, the MRI, a negative MRI doesn't rule it out, and even LPs have a different sensitivity depending on the times you've done the LP and the volume you get. So keep a high suspicion for leptomeningeal carcinomatosis in cancer patients, especially if they have multiple findings that are hard to localize specifically somewhere in the brain. So if you have these very different cranial nerves and other findings in a cancer patient, think about the leptomeningeal carcinomatosis, even if everything comes back negative, which in this case it didn't. So it was a great teaching case, Doug. So thank you so much for joining us. Hope to see some of you on Friday. Have a great week, everybody. Bye. How do I close this?